Muted. And I'm just going to do a quick intro for Jen, because she's such an amazing, wonderful person. And apparently I'm not, because everything just, nope, here we go. Go this way. There we go. Now I have it. So Jennifer Taylor-Cousar has been a primary investigator on more than 60 clinical studies and national and global primary investigator on 5 clinical trials. She is an elected member of the American Society for Clinical Investigation in 2020 and received the American Thoracic Society Patient Advisory Roundtable William J. Martin Distinguished Achievement Award in 2022. Her investigator-initiated research focuses on the development and evaluation of novel therapies for the treatment of CF and on the unique health needs of women with CF. She is also investigating the etiology and treatment of bronchiectasis in non-human primates. Her accolades just go on and on and on, and we are so honored to have her here with us tonight to discuss pregnancy, sexual and reproductive health in the era of highly effective modulator therapy. So at this time, I would love to turn the program over to Jennifer.
Yeah, thanks very much for the introduction. I don't know why my name said that I was you in my Zoom, but I just changed it. And I think we're saving questions for the end, but I think you can feel free to put them in the chat and then we'll get to them at the very end. And while my title is Sexual and Reproductive Health, I'll focus on pregnancy. I just feel like you can't talk about pregnancy without talking first about fertility and contraception. So we'll touch on those first. So these are my disclosures, most of which are related to the fact that I am the primary investigator on a lot of studies. So these are our objectives today. Understand the potential impact of highly effective modulator therapy, or HEMT, on fertility in females with CF, review the impact of CFTR modulators on contraceptive methods, understand historical pregnancy outcomes in females with CF and their infants, and what we need to know going forward, and then describe the potential risk and benefits of use of CFTR modulators during conception, pregnancy, and lactation. So all of you on this call are really well aware that the majority of people, at least in the US, with CF are variant eligible for highly effective modulator therapy. I say most because, of course, there are people who don't have a mutation that confers their ability to get modulators. There are some people who don't tolerate them. And then outside the US, costs are even more of an issue, and access. So, but here in the US, over 90% of people are at least variant or mutation eligible for highly effective modulator therapies. Now, of course, that's going to impact what CF looks like over time, and it really already has. So I had an older slide that was projections of how many adults we'd see with CF over the upcoming years. This is based on data that was presented at the North American CF meeting last year by Liz Cromwell. So on the y-axis is the number of adults with CF currently at the end of 2021, and then all the way out to 20 years from now on the x-axis. So at the end of 2021, there were about 19,000 adults with CF, so more adults than kids with CF. And over the next 20 years, we expect that to increase to about 33,000. So of course, as people are living longer and they're feeling better, more people are considering pregnancy and parenthood. So it's really critical, as you all know from this group, to have discussions about these issues in clinic. So again, I'll focus mostly on pregnancy, but I think it's important to talk about contraceptive use. So Emily Godfrey and colleagues, including myself and Dr. Raksha Jain, conducted a survey of 150 females with CF, aged 18 to 50, attending 3 major US CF centers. Between 2012 and 2016, we found that females with CF most commonly use combined hormonal contraceptions, barrier methods, long-acting reversible methods like the IUD or intrauterine device, or no method at all. Importantly, in this study and in others, we found that the unplanned pregnancy rate was around 50%, which is pretty similar to what we've seen in the population of people who don't have CF, but I think it's even more important to think about that now as we start to talk about use of modulators. But when we think about contraceptive methods, one thing that I think has been a point where people have some confusion is which of the modulators impact contraceptive, particularly contraceptives that are hormone-based. So all prescribers or all pharma companies are actually asked to do not only animal reproductive studies when they're trying to develop a drug, but they're also asked to check for drug-drug interactions or DDIs. So they did look at drug-drug interactions with contraceptive methods. And what they found was that Ivacafter, Tezacafter, and Lactation, so Kalydeco, Teziva would be Symdeco or Symkevi, and Teziva would be Trikafta or Kaftrio, depending on where you live. But Lumacafter is the only one that interacts with hormonal contraceptives. So the recommendation was that if you were using hormonal contraception, like oral contraceptive pills, that you couldn't use that as your only method. But that is not true for the other modulators. Now, again, these are only tested, by themselves and not in combination, but we know that those don't cause a problem. So Trikafta, Symkevi, or Symdeco, and Kalydeco don't cause a problem with contraception, or Cambi, or Lumacafter, Ivacafter does. Now, what about fertility in people with CF? I think my impression from clinic is that people have a much better understanding of this than they had in the past, although I do try to discuss this at every transition visit, because particularly males with CF, I've found in a lot of cases still don't know about fertility or didn't remember what their parents were told. So of course, most males with CF are infertile because of congenital bilateral absence of the vas deferens, but most females with CF, because their anatomy is similar to that of women without CF, those can become pregnant. However, there are some caveats to that. So again, although anatomy is similar, there are some factors for women with CF that can affect fertility, including thick, dehydrated, pH imbalanced cervical mucus. So there is a lot of CFTR channel in the cervix. So that, just like in your lungs or in your gut, if your CFTR channel in your cervix isn't working, it can alter the thickness of the mucus and also make it more acidic than basic. And sperm like it to be more basic than acidic. And it is harder for the sperm to penetrate the egg, or it's called capacitance. That is impaired if the environment is very acidic. Also in the past, particularly, there was delayed puberty and delayed ovulation in females with CF. And again, in the pre-modulator era in particular, there was suboptimal nutritional status, and all of those things likely impacted fertility. So although most females with CF can become pregnant, Steinberg et al. In Israel looked through records and showed that there was about a 35% subfertility rate in females with CF, which is higher than that in people without CF. The factors that were associated with having a more difficult time getting pregnant, which is what they call subfertility, were pancreatic insufficiency and, as in the general population, older age at first attempt. So the older you were when you first tried to get pregnant, the harder it was to get pregnant. As with some other series, they also reported that there were a lot of unplanned pregnancies. Now, again, going back to the point I made that the FDA, which is the Federal Drug Administration, and the EMA, European Medical Association, require that companies who are trying to get drug approvals test them in animal models. So not just to see if it causes toxicity for that animal, but also what happens if they give it to pregnant animals. And also determining whether or not it affects their fertility. So with all of these studies, it's important to realize that, again, these drugs were tested individually, not in combination. So for fertility, at normal human doses, none of the drugs had any impact on fertility. If you gave Ivacafter, Kalydeco, or Lactation, which is part of Trikafta or Kaftrio, if you gave them at really high doses, so 5 to 7 times, for example, of the maximum recommended human dose, or 6 to 7 times in the case of Lactation, then you actually saw some impairment of fertility, but not at the doses that we give on a normal basis. And in fact, as I alluded to, and as you guys, I think, started to talk about in your document, we think that you are going to be more fertile on highly effective modulator therapy, again, because there is a lot of CFTR in the cervix. So it could also be that you're improving your general health and nutrition, and your your cervical mucus is decreased. All of these factors may play a role, but I think the biggest one is really going to be the fact that your CFTR is now working in your cervix. And so what is some evidence? Because we don't actually have direct evidence of this yet, but some things that tell us that this is probably the case. So back during the Ivacafter trials, which again is a highly effective modulator in that it improves your lung function and your body mass index and your quality of life and your exacerbation rate by a big extent, 2% of the females in those studies who were supposed to be on contraception actually became pregnant. And our suspicion is that because they hadn't become pregnant in the past, they didn't know that being on Ivacafter would make it easier to get pregnant, and they became pregnant. Also, there were several case reports in the medical literature of unintended pregnancies on Ivacafter. And there was one survey done in the UK and Europe that showed that 7 females with CF who had reported previous infertility, in other words, they had tried for 12 months to become pregnant, were unable to, were able to do so on average about 3 months after starting Ivacafter. And then most recently, O'Connor and colleagues reported that 14 females with CF between 2 centers in the South achieved conception at a mean of 8 weeks after starting Alex/Tez/Iva. And 7 of those were actually attempting to conceive. So again, about 50% unplanned pregnancy, and 4 had a history of infertility. And you might, if you've ever read the PROMISE study, the one that's looking at what happens over other organs after you start Alex/Tez/Iva, they actually reported a number of pregnancies in their study as well. So we definitely think that it makes it easier to get pregnant, although the study that Andrea Rowe tried to do, it just didn't work out so well because people started taking their Trikafta so soon after it was approved. She didn't get enough pre-Trikafta cervical mucus to measure, but we do think that's changing cervical mucus and for sure is changing nutritional status, and it's going to make it easier for people to get pregnant. I wanted to show you this image because I think this really brings it home beyond what the words do. So if you look at the top image, it's something called hysteroscopy, where they're using a camera to look into somebody's uterus. And this first picture was taken on top, in a woman who was having trouble getting pregnant. And she hadn't been diagnosed yet with CF, but she got diagnosed with CF. She was started on Ivacafter. And that subsequent image, image B, is what it looked like in her uterus 3 months after she started Ivacafter. So you can see how that thick cervical mucus is now no longer an impediment to her getting pregnant. So I said that it's easier to get pregnant. What are people telling us about their desire to get pregnant? Well, there was a retrospective multi-center study in Europe and the UK of 605 women over the age of 18, and about 40% of them had attempted pregnancy. Tracy Kazmersky and several of us worked to survey 188 females with CF who were aged 15 to 24, and almost 80% of them said that they wanted to have a child in the future. And then in a smaller study that was really sort of a focus group, Holton and colleagues in Australia asked people about their attempts at pregnancy, and more than half of their group had already tried to get pregnant, and all of them said they wanted to get pregnant in the future. So people may have an easier time getting pregnant, and many people are saying that they want to become pregnant. And we're really seeing this bear out in the data. So this is data from the US CF patient registry. On the y-axis is the number of pregnancies, and on the x-axis is the year. I also superimposed the time of the phase 3 trials of the different modulators. And what you can see is that on average, there were about 200 or so pregnancies in the registry. When Ivacafter was being studied, those pregnancy rates went down and they boomed up a little bit afterwards. Of course, Ivacafter was only approved for a small number of people relatively. The same thing happened to a little bit smaller degree with Lum-Iva and Tez/Iva. And as many of us were expecting, with the approval of Alex/Tez/Iva, there was this huge boom. And so that in 2021, we had almost 700 pregnancies reported in the US CF patient registry. And I can tell you that I've gotten numerous emails from people around the world, because they always get approvals later than we do, about the pregnancy booms that they're seeing once Trikafta has been approved or Kaftrio has been approved in their countries. So what do we know about the impact of pregnancy on outcomes in people who become pregnant. Well, a lot of the data is either really old or from single sites. This first slide I'm going to show you is a database study from Chris Goss and colleagues who used the registry between 1985 and 1997. And they found that women with CF who became pregnant were healthier at baseline, not surprisingly, because at that time, people were really discouraged from becoming pregnant if they had a lung function that was less than 50 to 60. But those people who had a healthier baseline did actually have better survival compared to those who didn't become pregnant. And then in another older study that looked at a database from Schechter and colleagues that was done between 1994 and 2005, the females with CF who became pregnant, again, had a higher baseline lung function than those who didn't. But after pregnancy, they had more illness-related visits, more pulmonary exacerbations, including the need for IVs, and lower quality of life scores. And I'm sure those of you who have kids can understand why your quality of life scores might have gone down a little bit, especially in that first couple of months after you had your baby, because it's very exhausting during that time. But they did have lower quality of life scores. And then the females with CF who became pregnant did not have accelerated disease progression or more mortality, but again, these were women who had higher baseline lung function. There have been studies that looked at other databases that were non-CF databases. So for example, there are federal and state databases about complications in pregnant people that you can look at. And this group, Patel and also Jelen, looked at state and US-wide basically medical databases, they weren't CF specific, and looked at what were the complications in people with CF versus those who don't have CF in terms of pregnancy outcomes. And in terms of maternal complications, in females with CF, not very surprisingly, since the rate of diabetes is about 40% in adults with CF, they had a higher rate of diabetes during pregnancy, a higher rate of infection that really boils down to pulmonary exacerbations, they had higher rates of preterm labor, higher rates of gestational hypertension or high blood pressure and preeclampsia. And their infants had increased rates of congenital anomalies, including congenital cardiac anomalies. They had more rates of jaundice, there were more C-sections, and there were more premature deliveries. Again, this is all in the pre-modulator era. And there was a study presented that was a little bit more recent in 2020 by Ashcroft and colleagues who looked at an OBGYN database in the UK, and they showed that the lower someone's lung function was, the more likely they were to have a baby that had lower gestational age or was premature and was of low birth weight. But again, even that is in the pre-modulator era because it was reported in 2020. And that was done, and the database was looked at before Ivacafter or Kaftrio in the UK was approved. So again, thinking about modulators, because all that data I showed you was from mostly pre-modulator times, one of the animal reproductive studies that they also were required to do was to look at if there was any teratogenicity, or in other words, did giving modulators during pregnancy cause congenital anomalies in animal models. So in this case, they used rats and rabbits. And again, at normal human doses, there was no toxicity. At high doses, they did see a little bit of toxicity with tezacaftor, so decreased fetal body weight, early development, delay in the ear and eye opening. But again, that was at toxic doses. So at normal doses, there weren't any impacts in these animal models. But I did want to point out, because it was published within the last 2 months, this study out of France that some of you may have heard of. So essentially what they did was take baby mice, take their lungs out, and then put high doses of Kaftrio or Ivacafter on to these mouse lungs that were in culture. And they said when they did that, there was delayed development of the lungs. But even the authors themselves said this early mouse lung model is really an extreme model of exposure and is not similar to what's been seen in other models. But I did want to point that out. So if you guys wanted to ask questions about it, you could, because it was just published in the last, I feel like it was, well, this is still January, so probably the beginning of the month. What about drug exposure? So one of the questions you think about is like, okay, if the mom's taking Trikafta, is the baby actually seeing any of it? And from the animal models, again, we already knew that the answer was yes in animal models, but what about in people? So Aaron Trimble, who's at University of Oregon, worked with some other people, including the pharmacology physician at UNC, to look at what was happening in moms and babies when they were continuing on their Alex-Tez-Iva. They had actually shown with Lumaiva that you could detect levels in the baby. And they just recently in 2021 published that yes, if you measure in the baby, either with cord blood, so the blood at the time of birth or afterwards, yes, you definitely see levels of both Ivacafter and Tezacaftor as well as Alexacaftor in the baby. And those are on order with the levels that you see in mom, which isn't surprising during pregnancy because mom's blood is going to the baby. So the levels are pretty close to what mom sees when she is taking these drugs. And that's really important in considering medication safety, both during pregnancy and, as we'll get to a little bit later, during lactation or breastfeeding. So with the FDA, they actually used to have categories that were A through D or X. So A was like, we've seen lots and lots of evidence in people who were pregnant and their babies, and we have no concerns, versus X was, we've seen what happens to people and it's not good. It actually hurts the baby. But they thought that was too simplistic. And so they actually developed a new rule called the Pregnancy and Lactation Labeling Rule. And they were really hoping this would provide clinicians with more information to have informed discussions with their patients. So the requirements for this rule are that they have to say whether or not there are adequate and well-controlled studies in pregnant women to say if there's a drug-associated risk either with major birth defects or with miscarriage. Then they also have to say how much of the drug was given compared to the maximum recommended human dose, which you saw in some of those slides, and what happened to the fetus as a result. So really, when we're talking with people with CF about these risks and benefits, we have to weigh the risk of continuing a drug, in this case, highly effective modulator therapy, versus stopping the drug. And in some cases, there is real risk to stopping. So why do I say that? So Scott Donaldson and Aaron Trimble actually published back in 2018 something that they called Ivacafter withdrawal syndrome. So on the right, you see graphs of people's lung function, and the arrows are points where they had to stop their Ivacafter or their Kalydeco because of insurance issues. So you can see that with those sudden stops in their Kalydeco, they had declines in their lung function. And unfortunately, one person even died after they ran out of their Kalydeco. There was also a case series that was reported at the North American meeting in 2018. They looked at 10 adults who were in the Alex-Tez-Iva phase 2 study. So before you had the opportunity to go on open label, in phase 2, you got drug or placebo for 6 months and then it just went away. And they showed that in their trial participants, 7 out of 10 of them had lung function decline after they were out of the study, and 5 of them experienced pulmonary exacerbation. So we know that certainly some people who stop their drug are going to feel badly right away or within a couple of weeks of stopping their drug. And so that's why we have to weigh the risks or unknown or uncertain risks to the baby compared to those of the mom. Now, back in 2020, we just really didn't have much human data. And at that point, there weren't a lot of funders who were willing to look at pregnancy in CF. So myself, Ed Nash, who is from the UK, and Peter Milton from Australia, did a survey of providers and asked them to go through their charts and not provide any names or birth dates or any information that could identify who was in the study, but just looking at charts and telling us what happened to women when they stayed on their modulators or stopped them when they were pregnant with IVA, LUM-IVA, and TES-IVA. So 2018 to 2019 is when we studied IVA and LUM-IVA, and then 2020 to 2021 was when we looked at Alex-TES-IVA, and I included Dr. Jane in that study as well. So what we found in a summary of those two surveys was that in 135 females with CF, the use of modulators during part or all of their pregnancy resulted in only 4 maternal complications that were deemed related by their treating physician to CFTR modulator therapy. And those 4 things were 1 case of acute myelocytic leukemia in somebody who took Orkambi. And that one is really unclear because there have been no reports other than that one where the providers speculated that was what the problem was. There was also a pulmonary exacerbation that was attributed to use of Orkambi. And then there were 1 case of a woman who got cholecystitis or acute inflammation of her gallbladder during pregnancy, which the provider thought was related to use of Trikafta, and 1 case of elevated liver enzymes. But those were the only 4 that the provider said, yes, we think it's probably related to the modulator. The miscarriage rate for females with CF in this survey was less than 10%. And in the US, at least 10 to 15% is what we see in the general population. So the miscarriage rate was consistent with the general population and not at all affected by modulators. I think it's important to realize that if people stop their modulators, about 40% of those people actually had to resume because they either had a pulmonary exacerbation or they had an episode of pancreatitis. Most often, it was a pulmonary cause that caused them to go back on their drug after they tried to stop it because they were uncertain about the effects on the baby. There were no modulator-related complications as deemed by the treating physician in any of these babies that were exposed during mom's pregnancy. So out of 135 that we collected data on. Now, when you do a retrospective survey, there's obviously risk for a lot of bias. So it's like, what does the doctor remember? What did they write in their chart? And if with the survey, you saw that it was only 2 pages. So again, while we were trying to get funding for a prospective study, which I'll talk about later, Dr. Jane and I worked with the foundation to develop and get funding for a bigger retrospective study where we actually had people go through in detail and get information from charts to sort of try to figure out what's happening in the modern era. Because again, all the data that I showed you in the beginning of the talk was about pregnancy outcomes in the pre-modulator era at a time when people with CF who were getting pregnant were more likely to be healthy because those who didn't have high lung function were discouraged from getting pregnant. So in this retrospective study, we actually collected data from 2010 to 2021. So mostly what we would have captured is pre-modulator and Ivacafter or Kalydeco and Orkambi and Symdeko, and just a tiny bit of Trikafta. There were 350 total pregnancies in 271 different individuals. The average pre-pregnancy health measures were average age of 28, almost 29, average lung function of around 74, and a BMI or body mass index of 23.5, which is within the range recommended by the CF Foundation. So these charts are a little bit small, but they're very similar. So we're looking first at adjusted change in lung function over time. So pre-pregnancy compared to post-pregnancy. And this is exacerbations, and this one is looking at BMI. The dotted black line is no modulator. The dotted or solid black line is the non-highly effective, so Orkambi and Symdeko, and the blue line is highly effective modulator, so either Kalydeco or Trikafta. So you can see that if you were on a highly effective modulator, your lung function actually appeared to go up post-pregnancy versus those who were on no modulator or the less effective modulators, in which case it went down a little bit. For pulmonary exacerbations, the p-value wasn't significant. So even though there may look like there were changes, they didn't reach the level of accuracy that we think they were significant. And then if we looked at BMI, again, for those people who were on a less effective modulator or no modulator, their BMI was about the same, but those who were on highly effective modulator therapies post-pregnancy, their weight actually went up, which is, something that we worry about in people post-pregnancy, because especially if people are breastfeeding and using tons of calories, they are very likely to lose weight after their pregnancy. And some people, at least in the pre-modulator era, had to stop breastfeeding just for that reason. So with this database, we also looked at what happened if you had planned your pregnancy versus if you were surprised to be pregnant. And so what we saw was that there were 136 people for whom we could determine that they had planned their pregnancy based on the chart review versus 90 pregnancies that were unplanned. If you looked at the baseline health in those who planned to get pregnant versus those who hadn't planned to get pregnant, the people who planned to get pregnant were a little bit older, 31 versus 28. The lung function of those who planned their pregnancies was a bit higher at 82 versus 65% predicted. And then BMIs were also higher for those who planned their pregnancies versus those who had not. And then if you look at the changes in lung function, body mass index, and pulmonary exacerbations, you can see that although they didn't reach significance for lung function and BMI, it did actually reach significance for pulmonary exacerbation. So there were trends towards having a worse lung function and a worse BMI if you didn't have a planned pregnancy, but there was definitely a higher rate of pulmonary exacerbations if you had an unplanned pregnancy. Just again, reminding us as clinicians that we need to talk to people about increased risk of pregnancy, or if you want to have a baby, that's a good thing, on these modulators, and really discuss that in clinic, because the outcomes on health were worse if a pregnancy was unplanned. We also looked at what happened with the infants in the planned versus unplanned pregnancies, and you can see that there were higher rates of preterm delivery, C-section, lower APGARs, and less ability to or willingness to breastfeed in those who were or had unplanned pregnancies. So again, this is for us as providers to really remember we have to have these discussions. And of course, they're going to be unplanned pregnancies in despite of everything. And that tells us that we have to be more careful about monitoring people if they have an unplanned pregnancy, because they are at risk for worse outcomes in their own health and worse outcomes for their baby's health. And one other thing that I wanted to touch on briefly is pregnancies in transplant. So most transplant centers counsel people against pregnancy post-transplant because we know that maternal and fetal complication rates are much higher. So I've already showed you that they're higher in females with CF, at least in the pre-modulator era, but being someone who's post-transplant, those risks are even higher because of the drugs that people have to take to continue the health of their transplanted lungs. And if you decrease those medications, then you put the woman at risk for higher risk of rejection, which over time can again cause failure of her transplanted lungs. So there was one study from 2012 that specifically looked at lung transplants. They had data on 21 females, and 10 of those females had CF. There were 30 pregnancies that were described, and they collected this data from the National Transplant Registry. There were 18 live births, 5 intentional abortions, and 9 spontaneous abortions amongst those 30 pregnancies. And then if you looked at maternal complications, as I indicated, they were fairly high. So 16 out of 18 had gestational hypertension, 7 had diabetes, and 7 had infection. There were 5 who experienced rejection and 1 who had preeclampsia. Postpartum, there was 1 person whose transplant was no longer working. There were 2 who had reduced lung function and 5 who actually died. And then in terms of the infant complications, 11 out of the 18 were preterm. There were 11 who were low birth weight and 2 unfortunate neonatal deaths. So definitely higher risk. So if you go to the CF Foundation website, they'll say, talk to your transplant center. And again, most transplant centers will discourage it, but if someone is going to have a baby after transplant, they ask that you wait 2 to 3 years so that you're in less of a window of having a high chance of rejection as your medicines are lowered to make it safer for the baby. So another topic that's come up a lot recently, and I've gotten emails both from docs in the US and outside the US, is what about treating babies with CF in utero with modulators? So in the US, the current approvals for modulators are for Ivacafter or Kalydeco for babies who are 4 months or older. Lumivah is approved for toddlers who are 2 or older. The studies for Alex/Tez/Iva in 2 to 5-year-olds were completed, and the data are currently being reviewed by the FDA. We're expecting that they will probably approve Trikafta for 2 to 5-year-olds in 2023. But there are also recent reports of babies who either have 1 copy or 2 copies of F508 who have been exposed to Trikafta during mom's pregnancy because mom had CF, or in one case did not have CF, was a carrier, but took Trikafta during pregnancy. So the first case that was reported out of upstate New York was a female infant who had a normal newborn screen, so a false negative newborn screen, because she was pancreatic sufficient at birth in spite of having 2 copies of F508. So for those of you who haven't thought about newborn screen for a while, every state starts out with testing for something called immunoreactive trypsinogen, which is basically a measure of pancreatic function. So most babies who have CF are going to be born with insufficient pancreas. But this baby had pancreatic sufficiency, and so therefore newborn screen was false negative. And when they did her sweat test was only 60, whereas you'd expect it to be around 90 to 100 for a baby who has 2 copies of F508. So she was definitely getting Trikafta from her mom while she was in her mom's belly, but also because mom continued to breastfeed, she was continuing to get low levels of Alex/Tez/Iva there and was continuing to do well. So she had this very early exposure. There was another female infant who recently was reported who on prenatal ultrasound, they showed that the baby probably had meconium ileus. So about 20% of babies with CF are going to be born with meconium ileus, which is stool blockage in the gut before they're even born. And they showed this at 23 weeks gestation. So the doctors started the mom on Alex/Tez/Iva or Trikafta, and the meconium ileus resolved before the baby was born. And this final case, which I think is really exciting, because right now, if you're already born and a male with CF, we can't reverse the congenital bilateral absence of the vas deferens. But we postulated, based on data in the ferret model, that if a baby male ferret got a highly effective modulator like Ivacafter in utero, that we might rescue the vas deferens and make them fertile. And that was shown in baby ferrets. In this case, in this baby male with CF, he again was born with a normal or a false negative newborn screen and only had a sweat chloride of around 60 in spite of having 1 copy of F508 and a copy of a nonsense mutation. But he received Trikafta in utero, and then mom continued to breastfeed. And he actually, as of the report by Dr. Fortner at NACFC, has a palpable vas deferens. So even though most babies, almost all of them who are male, are born without that vas deferens, he actually had a palpable one, meaning the urologist could feel that it was there. Now, whether or not it works, obviously we won't know that until he's older, but at least actually for the first time, we've shown that you can actually rescue the vas deferens in a male with CF if they're treated in utero with a highly effective modulator. So I mentioned breastfeeding a little bit, but I'll point out again that yes, we saw the fact that you could transmit a modulator in breast milk based on the animal reproductive models, but something that's really also important to note, because it's in the package insert, so the prescribing information for the doctor, it actually says that if a child, so anybody under 18, is exposed to Ivacafter or anything containing Ivacafter, that you must check for cataracts, because when they directly gave baby rats Ivacafter, those baby rats developed cataracts. Now, of course, baby rats are not people. And I mentioned a few minutes ago that Ivacafter is approved down to age 4 months. And we have not seen a rash of cataracts in babies who take Ivacafter, nor in little kids who take it. But this is in the label as a warning because of what happened to baby rats. And I mentioned already that, and you guys actually know, you didn't see it yet. So they actually did look at this when Aaron Trimble and Scott Donaldson measured Lumacafter, Ivacafter in the infant that I mentioned earlier. They also measured breast milk and showed that it was there. So this is their bigger graph that they presented in their paper. And so I already told you, and I showed you this one where you can see that at the time of birth, the levels in the baby are pretty similar to what the levels are in mom, which makes sense because at that point, they're getting all their blood from mom. But then if you look at these other graphs, we're looking at the concentration on each of these y-axes. And then this first one is maternal measures of Alexa, then infant measures, and then measures in breast milk. And then along the x-axis is the days from delivery. So of course, levels are all similar here. And then over time, mom's continuing to take it. And while the baby is breastfeeding, they are continuing to have detectable levels in their plasma, even though they're lower than what moms are. And then if you look directly in breast milk, again, you can actually measure it there. So for sure, babies are being exposed to these modulators through breast milk, but at a much lower level. And that's why, if you remember back to the baby, and I said the baby's sweat chloride was 60, well, we'd expect that if the baby was directly given Alexacafter, Tezacafter, Ivacafter, their sweat test would probably be in the 30s, because kids drop their sweat chlorides into the normal range really easily with these highly effective modulators. But because she was only getting it through breast milk at that point, her sweat chloride was around 60. So she was getting a little bit, but not quite enough to be what we would call therapeutic. So we did actually ask about what was happening to babies in our survey when their moms were breastfeeding. So 69 infants were breastfed while mom was on her modulator, whichever modulator it was. No infants were reported to have cataracts, but only 6 had a formal assessment. And it's really hard, like a pediatrician can't just look unless someone has a really, really large cataract. It would affect their those of you who have babies, the pediatrician flashes a light into their eyes and looks for their red reflex. If you have a gigantic cataract, that would be seen. But to see tiny ones, you have to have an ophthalmologist, a baby ophthalmologist, look in the baby's eyes. And only 6 of the moms had had their baby's eyes formally tested. There were no reports of modulator-related liver function test abnormalities in these breastfed infants in our study. But more recently, Dr. Jane and myself and Michelle Steinberg from Israel reported about babies that were exposed in utero and via breastfeeding. And in this case series, so at UT Southwestern and at the center in Israel, every single mom who had any modulator exposure took their baby to get tested. And out of 23 infants who were tested, 3 of them had very tiny cataracts that were considered to be clinically insignificant, but were present. We don't know whether or not babies who are born to moms with CF are more prone to cataracts. We know that people with CF in general are more prone to cataracts, but we don't know if babies who don't have CF and are not exposed to modulators are more prone to cataracts. So we really do have to do a prospective study looking at both babies who were exposed and babies who were not exposed to figure out whether Alexa or any modulator is increasing that risk. So based on all of the knowledge that we have to date, we did work with the CF Foundation to create some general guidelines for newborns and infants being monitored when mom was on modulators. So we said that you should consider cataract screening because of the data that I just showed you. we said that if a baby has newborn screen, you have to realize that they could still have CF because the pancreatic sufficiency issue will be impacted by taking highly effective modulator. So if the dad's a CFTR carrier, or if the dad's status is unknown, it's really important for that baby to have a sweat test and CFTR genotyping. And then in terms of liver function tests, again, we did not see reports of abnormal LFTs in the survey data we did. However, there have been case reports where they said, well, the baby's LFTs went up and down, and we're not really sure whether it was related to modulators. So it's something that the mom should talk about with her pediatrician. Most pediatricians here in Colorado are electing to measure them only if there's an issue with the baby, because they don't want to have to keep giving the baby extra blood sticks. But that's variable by the doctors in each person's area, and so they should talk to their baby's pediatrician. So just in the last few minutes, so we can have a few minutes for questions. So we're still also trying to figure out what happens with parenthood, because we know, again, that people are very busy and tired, especially in that first year of being a parent. So we did look retrospectively, again, back in time using a registry, in this case, the UK registry, because unfortunately at this time, the US registry doesn't collect anything about males with CF who become parents. So this had both males and females who became parents. So a dad would have had his partner's pregnancy recorded here. And what we found was that people's lung function did drop a bit in the year after they became a parent. BMI, or body mass index, went down, and people's pulmonary exacerbation rate went up. We did find that for those who were on even the less effective modulators, those impacts were mitigated by modulator use, but we really need to study that again prospectively. So both of these things will be studied prospectively and are being studied prospectively. So several of you may have heard of the Mayflower Study, which is the maternal and fetal outcomes in the era of modulators. This started in September 2021, and at this point, we've enrolled over 100 females with CF. So if anybody on this call is on the study, thank you very much. This data is so important to so many people. So we're studying people while they're pregnant. As soon as they find out they're pregnant, they're eligible to enroll if they plan to continue to be pregnant. And then we're following them and their infants out for 2 years. These are all the sites that are participating in the Mayflower study. So about 40 sites. And our primary measure is what is the impact on lung function, but we're also looking at weight. We're looking at pregnancy complications, because I told you that they in the past were higher in females with CF, and maybe that's changed now in the setting of modulators. We are also checking on people's not just quality of life, but also on whether their anxiety and depression rates are changing with pregnancy and parenthood. We're looking at delivery outcomes, and then again, we're following the babies out over 2 years. And for those of you who want to look more on clinicaltrials.gov, this QR code is actually active, and you can look at all the sites and what our outcomes are on clinicaltrials.gov. The other study that very excitingly just got co-funded by the NIH, so it was already funded by the CF Foundation, but we received word last week that it's also going to be funded by the NIH, is the HOPE CF study, which is health outcomes of parents with CF. So again, we're going to be looking at lung function decline in those who become parents versus those who don't. And we're also going to be looking at mental health. And really, this is not to say being a parent is bad for your health, but really, like, what are the problems that we see, and how can we help people and support people to have good health outcomes and become parents? Because we want people to not just live longer and feel better, but to do all the things that they want to do. And if being a parent is one of those things, we want to be able to support them appropriately. So in conclusion, females with CF have reproductive anatomy that's very similar to that of women without CF, and the use of highly effective modulators likely increases fertility. The number of females with CF who desire and are having kids is increasing rapidly. In the pre-modulator era, females with CF who became pregnant and their infants had higher rates of complications. In our retrospective study of females with CF who used modulators during pregnancy and breastfeeding, we did not see alarming safety signals. We did see that short-term health outcomes were adversely affected in the year after parenthood, and they were mitigated by even moderately effective modulator use. But the bottom line is that for both pregnancy and parenthood, we really need prospective data that's happening in the modern era of the use of highly effective modulators. And both those studies, as I said, are either already started or will be starting soon. So with that, I'll say thank you to all of you for the invitation to speak and for your attention and for participating in trials. If you have done so, these centers are the ones that contributed data for the retrospective work. And of course, we had funding from the CF Foundation, and there's a family here in Denver who has also donated a lot of money so we could get some of this work done. So with that, I will stop and take any